This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone. This is Andy Southerland from the University of Virginia. And for this week's Neurology podcast, I have the pleasure of conducting another one of our episodes of the Physician as Patient series. This is a series we've been doing here at the Neurology podcast and conducted some live on-stage interviews at the annual meeting, allowing our colleagues in neurology from around the world to share their own experiences as patients and how it's influenced their practice as neurologists and how it can help others who are out there listening. And for today's episode, I'm very pleased to be speaking with friend and colleague Eric Seachrist. Eric is an associate professor of neurology at West Virginia University. And Eric had actually listened and heard our interviews at the annual meeting and reached out and was kind enough and indeed courageous enough to come on and share his story, his perspective. Eric is a neurologist and also a patient with multiple sclerosis. And so, Eric, let me just say, first and foremost, thank you for giving your time to come and join us for the podcast today.
Thanks for having me.
First thing we want to know is a little about you and then just share your story as both a patient and a neurologist.
This is now my 6th year of being an attending, which is hard to believe. I'm at West Virginia University. I'm a general neurologist. I started straight out of residency and just joined staff. And oddly enough, I took over the MS clinic for a period of time until our subspecialist arrived from the University of Virginia. So that gets into the story of what happened to me. So when I was in my last year of residency, PGY4, I had been asked a month prior if I wanted to take over the multiple sclerosis clinic because our specialist had just left and we had one coming. So we had a 9-month gap and I had a lot of interest in it already. And whether that was fate or a poor choice, I don't know. We'll figure it out. But a month later, I was actually at the stroke conference in LA. And then I noticed in the shower, I was taking a hot shower and my left leg did not feel hot. I was like, well, that's strange. And of course, I ignored it, thought it was a sunburn. I scratched the leg. It didn't feel scratchy. Other side, it did. Outside of that stimuli, everything felt normal, otherwise asymptomatic. And the next day, I took a 5-hour direct flight back home and I flew a budget airline. And then I went to stand up and my right leg gave out. My knee buckled. So I thought I somehow hurt myself on this budget airline. And then I carried on with my day. But over the next few days, it kept happening more and more, where my knee would give out on the right, more and more trouble going up and down hills because I walked to work at that time. And then stairs were really getting more troublesome. And then by day 5, I noticed I had some trouble writing my name. I'm right-handed, so that was a little strange. But again, continued to ignore it. Didn't really think much of these symptoms at that time. And then by the afternoon on day 5, I was sitting in lecture, and then I could no longer make a fist. And then I tried to spread my fingers out on the right hand, and I couldn't. So that's when I really got worried. Something was wrong. I had one of my co-residents do a quick exam on me, and they thought I was putting them on or something or playing a joke, but I was not. And I got a quick assessment and then sent home for a little bit to see if I'd feel better. No one was really sure what was going on because at that time we didn't take into account the leg or any of those symptoms. It was just hand. And I was sitting at home. I was supposed to be on home call and I got pulled off that shift. And then I was testing my reflexes at home because what else would a neurologist in training do with their time?
Very neurologist as patient and experience there.
Because at that time, I didn't know, is this central? Is this peripheral? Is this like a plexus thing? Who knows? And then I noticed I was pretty brisk. And then I actually was able to get clonus in my right ankle. And that's when I knew this was a central process. And that's when everything hit. And there was a whole lot of terror. And then I had one of my co-residents come and do more of an appropriate exam. Yes, I was definitely hyperreflexic. And that's when we called and I got admitted to the neurology service.
My goodness, that is a harrowing tale, Eric. And to be at that stage in your life, when compared to a lot of our folks who have been on for this series of podcasts who have had issues for a longer period of time before they got into medicine, et cetera, you're already in practice as a neurologist. And so enough to know enough, and that can heighten anxiety, heighten concern. It can also ideally help you get evaluated sooner. But I can imagine that during that time, that was a very frightening time for you. But in some ways, I'm sure a relief to ultimately be able to figure out what was going on and get the support and get a plan together at that time.
Was admitted. I got an MRI fairly quickly once I was in there, and then showed a contrast enhancing lesion of the lower cervical spine, very typical of transverse myelitis. and I got steroids and actually made a full recovery in a month. And in that workup process in the hospital, I had other MRIs, of course, and then I also had a spinal tap. And a little bit interesting story with that. Only one of the residents was excited to do the spinal tap on me, and this was one of my juniors, and he was too excited. So we just passed on that one, and I did it under fluoro.
Well, Eric, that is a very difficult crossroads to be at, confronted with this diagnosis as a neurology resident. Just to emphasize, you're a senior neurology resident when this is occurring. You've already accepted a position at your home institution. Not only that, you've accepted a position to take on some leadership of the MS clinic, and then here you are being diagnosed, I suppose at that time, with a clinically isolated syndrome. Not only that, but getting this diagnostic workup, which includes your own fellow residents potentially doing a lumbar puncture. Going to fluoro was probably, a suggestion for you at the time. But I think that's amazing to underscore the collision of where you are in your career at this point, burgeoning on your first step as a faculty neurologist when this all goes on.
I learned a lot about autoimmune neurology in a short period of time.
I bet. There's one's education, and then there's educating oneself when something like this occurs. I'm not to be glib, but no doubt likely prepared you for taking on leadership of the MS clinic in a whole new way, I suspect.
Definitely got some experiences that I can share and use.
So from that point forward, you're getting this initial workup, you're a senior resident. Where does it go from there? I'm curious, both in the immediate time period when you're trying to searching for this ultimate diagnosis, which ends up being a diagnosis of multiple sclerosis, and then a management plan, and then taking that forward now. I think you mentioned earlier in the podcast, you're 6 years as an attending. And so maybe both what happened next, and then also how has that influenced you or shaped you here in the early part of your career?
So I left the hospital after all the workup with a diagnosis of clinically isolated syndrome. So a one-time demyelinating event. We were all hopeful that it was just some sort of post-viral transverse myelitis thing. And I got a second opinion at another kind of large academic center who agreed. And at that time, it was mostly recover with PT, which I did. And I was essentially asymptomatic within a month. I went back to playing basketball with residents, still badly. So it didn't really change that. But I tried, gave me an excuse. But I've had follow-up MRIs. I had it at 6 months and then at 12 months. And going through that period, that was probably the worst period of time, was when I was in that clinically isolated syndrome period, because I was waiting for something to happen. Because any new event, that's it. Then it's a formal diagnosis. It's a chronic disease. So anytime I woke up and my hand was a little tingly from just sleeping on it, it jumps into your brain. You get a migraine aura, which I do get those from time to time. That was going into my head too. So it was a very anxiety-provoking period. And certainly working in the MS clinic, I was getting a daily reminder of, oh yeah, by the way. But it did allow me to really empathize with the folks in that situation, because the not knowing, it was really a really challenging period. Once then we got treatments, we can do stuff. But it was that in between where it didn't seem even worth it to do strong immunotherapy. That was a really challenging period. And I was learning a lot over that time and working with it. And then at the 12-month mark, I had a follow-up MRI brain, and I had 2 new asymptomatic periventricular contrast enhancing lesions. So that sealed the diagnosis. And just since I worked there and I was at the time the MS person, although our other provider had arrived and was taking over my care.
We're shouting out to our mutual colleague, Melanie Ward, our
Yes.
MS clinic there at West Virginia University. Shout out, Melanie, if you're listening, but in any event.
Yeah, very happy to have her as my MS neurologist and colleague every day. I ended up, just because everyone's here, it was an odd experience. Got a second opinion, again, from a large center, and that did not go well. I got a sense of how important it is to really prepare and to listen and hear people out. The experience I got was more or less, it didn't matter my training, it didn't matter anything that I'd been through. Basically, I was just another person showing up in the clinic. They hadn't prepared and looked at my images. They didn't see the new lesions. And when I was there for an opinion of what medicine to start, when I already had a good idea what I was going to do, I just refused to give me an opinion. They were trying to enroll me in a clinical trial, which I did not appreciate. So it was a challenging encounter and showed me some of the other side of academics. But I use that experience a lot, and I really do my best, even though I'm not perfect. And I have days where I'm not as prepared as I need to be for my patients, and really try to be there and try to listen, because it's so critical, even just to hear people out. The communication that we do as neurologists is far more important than any of the medicines we prescribe or even the diagnoses we come up with. is just talking to people and listening to them and being present, which is hard to do. I have to remind myself each day, okay, I stop outside the room, okay, clear everything else out. I'm here for this person. Let's do this, forget everything else. And so I learned a whole lot from that experience, even though it was not a good experience, but I took a lot from it. And I really tried to use that every day to be the best I can for my patients.
There are a number of great lessons in there. And one of our important questions that we always include in this neurologist, physicianist, patient series is how can we educate neurologists in training, neurologists in practice who are developing their style and their relationship with patients, so forth. And I think for you, it sounds like it's an obvious scenario where I think as junior neurologists, as residents, as students in training, we're often feel compelled to regale patients with how much we know, and even to the extent of being proud of what we can tell them that's not happening and excited and so forth. Whereas the patient may be experiencing a lot of anxiety about that. And as you said, waiting for that other shoe to drop in that in-between zone. And then clearly we're all immersed in this sort of high throughput environment nowadays, whether in academics or community practice, where every patient becomes another docket in your template, and how important it is, how challenging it is, as you point out, to really be present and to recognize that for you, it could be one of 20 patients you're seeing in a day. For them, it's the most important 1 hour, 30 minutes or less of perhaps of their entire life, certainly of that time in their lives. I think that's difficult to maintain in our busy lives that we all lead.
Absolutely. You just try to remind yourself. And one of the strategies I've been doing from that experience is, I'm used to typing my notes as I go, being at the computer where I'm talking to the patient, which is good. You have to do it for efficiency. But once you get a sense that there's something hanging in the room, there's a feeling there that needs addressed, or you need to say something serious, or you feel like you're losing them, I push myself away from the computer and it's just one-on-one. And that seems to do a lot. I'll have to make up some note time later, but that's okay.
Yeah, no, that is a real challenging issue in the modern electronic medical record and documentation requirements, particularly, again, for residents who are just under the gun constantly, who we both work with. But I hear you say that is powerful. The founder of our podcast, who really inspires a lot of what we do here, Ted Burns, he wrote about this in the Neurology Journal, the importance of monotasking when you're in the room with a patient, of not allowing the computer to be the third party in the doctor-patient relationship. But as somebody who also gets behind in their notes and their documentation, and you don't want to, of course, take that home and erode, the importance of that, it's trying to find that balance of where you really can hone in the patient. And I like what you said, Eric, really listen for the key moments when that's necessary. And then at other times, you can be taking and adding in history and details and so forth in the commuter as needed. But it's a skill that's not taught in textbooks and in the classroom. It's often learned through experience.
It's tough, but it's so critical.
Eric, I've learned a lot. I think, as with all of our colleagues who come on this podcast and share their experience, share their stories, I'm constantly amazed that you're able to balance it all. Are there any final lessons you feel like you want to share for the listening audience? Again, thinking about the person listening to this podcast right now who is just like you or others who have been patients, or perhaps even in that in-between zone that you talk about, which is really probably the most harrowing part of it, is when you're in the unknowing part. And do you have any final thoughts to share?
I think for me, you can let a diagnosis like this sort of take over and be a constant distraction and be always ever present in your mind. And for me, the way that I took more control over it was to own it, to be open about it, and to use it as a teaching tool. So when the med students rotate, I'd give them a lesson about how you diagnose MS and also how to localize a cervical spine transverse myelitis. It's a great Brown-Séquard syndrome. And that's just how I've been able to be in control of it rather than it control me. I'm also very fortunate that it was diagnosed very early, mostly asymptomatic and on high efficacy therapy that works really well. And using it as an education tool, as a learning tool, and to use it for good. Also in the community. So I do a good bit with the National MS Society and our walk that comes out, try to do some fundraising, just do what you can to impact in a positive way.
Who better to give that lesson to students and residents than you, and no better lesson to share than to be able to take control, have control, and also turn it into a positive give back, which you're continuing to do here by sharing with us here at the Neurology Podcast. So with that, I want to give my sincere thanks again to Eric Seachrist from West Virginia University for sharing in this latest installment of the Physician as Patient series. I hope all will listen, and please feel free to reach out for anyone listening. If you're out there and you're struggling with health-related issues or you have a story to share, please reach out to us. You're not alone, and we look forward to hearing from you. So Eric, thank you so much again, and I look forward to our next conversation.
Absolutely. Thanks for having me.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.